This is case of the day, and today is Thursday, and we're on our 174th case. But before I start on the case, let me just show you something that I've been doing for the last 2-3 days. So YouTube has posts of the day. I mean, not posts of the day. You can just put posts, and I put up 3 posts earlier today, and then I done couple couple of days ago, and then 4 days ago, where these are single images that prove a point, and I just put it up as a teaching point. So the way to access these is to go on to the site, and you'll see the posts, and then you can go through them, and I think you'll be able to go through each post in about a minute or 2 minutes or so. But today's case is case 174, Scleroderma and FANO. And you must have realized that at heart, irrespective of what cases I put up, in the end, it all comes back to diffuse lung diseases. And so this is a 33-year-old with scleroderma. This is the CT. You see reticular opacities, temporal spatial homogeneity, subpleural basal predominance, traction bronchiectasis, no honeycombing. And this is a classic NSIP pattern. So this is scleroderma related fibrotic NSIP pattern. And so the lower lobes are classic NSIP. But what do we call these lesions in the non-dependent anterolateral upper lobes? Is this also NSIP? Is this something else? Well, till a few days ago, I would just say that everything is NSIP. But then I came across this paper earlier last month that basically talks about histopath findings in patients with scleroderma, and this is typical of the physicians in Japan, where even our entire understanding of DPO, CIOP, PPFE, everything has come from Japan, from that tiny small country, because they obsessively document and biopsy these patients. So here they've biopsied 28 patients of scleroderma ILD, and they found that of these 28, 21 had the NSIP pattern on CT, which was confirmed on pathology in 17, and then you can see the rest here. And the findings were ground glass consolidation, reticulation in combination. But then they had this term FANO, which is faint amorphous nodular opacities. And according to them, it's a potential early stage CT finding that they found in 18, that is 64% of patients, and pathologically corresponds to perivenular fibrosis, peribronchial metaplasia, with or without mucostasis, with both fibrotic and non-fibrotic components. And this is the image in the paper, and this is the image that our patient has that I showed earlier. Faint amorphous nodular opacities with typically subpleural sparing. And if you look at the histopath findings, so in this patient who has NSIP here, they've called this section as FANO, which is what was biopsied. And for those who understand pathology, this is where they're showing the perivenular fibrosis. Now, when they looked at the 18 patients with FANO, all of them had upper lobe anterior involvement, 4 had upper lobe posterior involvement, and 3 had posterior lower lobe, 6 had anterior lower lobe. And the commonest pattern they were associated with, as in our case, was the NSIP pattern. So again, the commonest is anterior upper, most commonly associated with NSIP. And they say that this is likely an early stage manifestation that may eventually progress to NSIP. And then came the curveball, that where they said that this is the term, while they didn't use the term FANO, this was what was described with asbestosis. So I went back to that case 95, and you'll find the link on the top right, where I labeled this the dots and bands of early asbestosis. And in fact, that is what it is. These are faint amorphous nodular opacities that eventually progressed over 9 months. And those early dots and bands, the histopathology corresponds exactly to what they've described here. And then they've given references where similar findings have been seen with dermatomyositis. And then I went back a few minutes ago to the scleroderma cases that I've shown in the past, especially the early ones. And if you look at case 94 at ctchestreview.com, I have a link on the top right. And I'd actually called this how early can an early scleroderma finding be? And if you see here, the subtle disease in the non-dependent lower lobes. In fact, here there's a little bit of cystic change, so you could argue that this is NSIP. But the non-dependent upper lobes are classic FANO. And this is a case from about 20 years ago where the patient had Raynaud's, and I've always kept it because this was an early appearance and we've always called this NSIP. But this actually just looks like FANO, faint amorphous nodular opacities. And I'm just repeating that so that it gets into my head and your head as well, because it's a little tough acronym to remember. So FANO lesions, again, faint amorphous nodular opacities, are an early interstitial manifestation of Scleroderma eyelie, also first described with asbestosis and also with a few other connective tissue diseases, most commonly seen in the anterolateral upper lobes, usually progressive, and commonly progressing to an NSIP pattern. So I've learned something new this month. I hope it's been the same for you. My WhatsApp channel, and thank you so much for viewing this.